بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على سيدنا رسول الله. Thank you, Mr. Chairman, for the introduction. Thank you for the scientific and the organization for general education. It's going to talk about PPM again. This is a different kind of PPM. We'll review electrical disturbances and pacemaker needs and update techniques to prevent. This is a case-based presentation. I have no. This slide is not moving. So no disclosures. I'm not an EP person. This is a patient that was involved in his care, at 82 years old, a male Saudi patient, diabetic with dyslipidemia, hypertension, CKD, prior stroke with minimal residual weakness, hepatitis C, limited mobility, and unilateral blindness as a complication of his uncontrolled diabetes. He's known to have degenerative aortic valve stenosis for a number of years. The patient had recurrent admission with worsening shortness of breath, labeled as class 3, referred from another hospital with recent hospitalization with presyncope. His lab investigation showed a low GFR and uncontrolled diabetes and high PNP level. His ECG might become relevant for this presentation. It can be easily passed as a normal ECG with normal intervals. His echo showed severe calcific aortic valve stenosis with normal ejection fraction. No other valves involved. Coronary angiography shows normal normal coronary arteries with no disease, which is really very surprising in this patient. The patient was evaluated for possible TAVR. A CT scan was done, and this showed significant calcification in the LVOT. This is passed as a moderate calcification involving the LVOT, and there is a grading system. This should be a talk for another day. The discussion and the heart team meeting whether to offer this patient TAVR versus SAVR, and if we offer TAVR, which TAVR should be good for this patient? Is self-expandable, balloon expandable? What are the risks, knowing that the LVT calcification regarding VSD, risk of annular rupture, paravalvular leak, and pacemaker insertion? And what is the risk of pre and post dilatation in such a patient? We've decided, many of you might not really agree to this, we decided to go with a balloon expandable valve. Procedure went well. But soon after we turned off the pacemaker, the overdraft pacing, the patient developed a left bundle branch block, which kind of was expected. So his post-TAVR ECG shows prolonged PR interval of more than 200 milliseconds, new left bundle branch block with a QRS duration of 100 milliseconds. Now the question, should we wait? Should we send the patient for an early pacemaker prior to discharge? We will learn in the coming few slides. So the TAVR related complication has declined with iterations of the new devices, improvement of the techniques, yet conduction disturbances are the most common and frequent complications. It's now the Achilles heel that we need to overcome in order to extend this to a younger and the low-risk patients. Now, the types of conduction abnormalities that can be seen, there is a specific definition for this conduction disturbance. It's a new conduction abnormality, first-degree AV block, new left bundle branch block, new high AV block or complete heart block with or without pre-existing conduction disease. Now, why it happens? Simply because the device rests on the conduction system. It's a close proximity of the prosthesis to the conduction system, and the mechanism is thought to be related to compression, hematoma, local ischemic injury. Luckily, majority of these conduction disturbances are really transient and resolved by the time of discharge of the patient in 3 to 4 days, and most of them are resolved within 1 month time. The incidence is really at the single digit with the balloon expandable and the 2 digits with the self-expandable, with the newer valve, especially the accurate new is the single digit. The TIFI registry shows that balloon expandable valves has a lower rates of conduction disease when compared to the self-expandable valves. An important complication is the left bundle branch block. The rates has been differing from different studies from 10 to 70%. This is really important because now we're extending this procedure to a younger patient, lower risk patients, and left bundle branch block is not really a benign by standard. Reports showing that the left bundle branch block is associated with increased all-cause mortality, hospitalization, poor LV function. And in an analysis of partner through a trial in an intermediate risk patient showed that patients who developed left bundle branch block at a higher risk of developing future cardiac events and sudden cardiac death. So really have to be very careful in looking for this complication and trying to avoid it if we are going to extend this to a younger patient with low risk. Now, the predictors, the most important predictor is the pre-existing right bundle branch block, in addition to the depth of your implantation and the response to a basing, presence of Winke-Bach after basing is another strong predictors. Bigger valve are again risk predictors. Calcification of the landing zone is again is a high risk for predicting future pacemaker. Techniques used to lower the chance is there are multiple techniques can be adopted. Avoiding pre and post dilatation can lower the incidence of pacemaker needs. The Midas study have developed a technique by measuring the length of the membrane septum by CT and deploying the device at a length shorter than the length of the membrane septum, and they were able to lower the left bundle branch block from around 29% to 9%, and the need for pacemaker from 9% to 3%. So avoid pre and post dilatation, understand the calcification distribution in the LVOT and in the leaflets, and adopt a Midas technique. Multiple predictive models have been developed to risk predict a patient who will develop this complication. The Emory risk score that depends on clinical presentation of the patient's syncope, ECG changes, and the device oversizing. The other risk score looks into the distribution of the calcification and the presence of right bundle branch block. This will predict which patient is likely to develop these complications. Another unique technique is adoption of a cusp overlap when you're using a self-expandable valve. This is a study from Europe, included more than thousands of patients. They showed that adopting a cusp overlap will lower the pacemaker significantly when compared to using other techniques with the self-expandable valve. So your approach to lower the incidence should be really individualized, understanding the patient's anatomy, identify the patient at the greatest risk by looking at the pre-existing conduction disease, by looking at the ECG, doing Holter before the procedure or the day of admission, minimize your depth of implantation to 3 or 4 millimeters from the non-coronary cusp, minimize pre and post dilatation, avoid oversizing, ascertain the length of the membrane symptoms, and less than 5 millimeters is at the highest risk. Adopt cusp overlap technique and choose a balloon expandable over self-expandable valve. There is a expert consensus report from the American College of Cardiology looking into those patients and trying to standardize the way we treat those patients. And they look into the ECG. Following the device implantation, I've classified patient into 5 groups. Group 1, patient without pre-existing conduction disease who develop no change during the intervention. Usually they remove the pacemaker wire at the end of the procedure, and they are observed overnight. If there is no changes, they can be discharged safely within the next day. If they develop ECG changes, specifically prolongation of the BR interval more than 20 seconds or the QRS complex more than 20 seconds, then probably those patients should be monitored. If the patient develop complete heart block, then probably they should be offered pacemaker before their discharge. Majority of the ECG changes will really resolve, and we can monitor the patient for 2 days. If they resolve their ECG changes, they can be safely discharged. Remember, pre-existing right bundle branch block is a major risk for pacemaker implantation. Right bundle branch block is associated with late and early mortality. 60% of patients with pre-existing right bundle branch block, they don't require a pacemaker. 50% remain pacemaker-free at 2 years. Now, group 3 patients are patients with pre-existing increase in the PR interval or QRS complex. Those patients, if they have a prolongation of the QRS complex of more than 20 seconds, or the absolute of QRS complex is more than 150, then should be monitored for a longer time, probably for 2 days in the hospital. And if they have complete heart block, then they should be offered a pacemaker. Group 3, patients with new left bundle branch block, like our patients, if they develop complete heart block while being monitored in the CCU, then they should be offered a pacemaker. If their ECG changes resolve, then they can be monitored for two days. If they show a progression to complete heart block, then probably they should be offered either an EP study or longer prolongation. EP study looking into the His bundle delay. If the delay of the His bundle is more than 70 milliseconds, then probably they should be offered a pacemaker before discharge. Left bundle branch block is frequent, post-TAVR in 10 to 70% of patients. 30 to 50% of those patients resolve partially or completely. 10% of patients progress to complete heart block. Luckily, late sudden cardiac death is only 1%. So group 5 patients are those patients who develop complete heart block during the procedure. 5% of those patients, they will have persistent complete heart block, and they should be offered pacemaker before their discharge. If this resolves, then you need to monitor the patient for 2 days in hospital. If it resolves, then you probably will study this patient with an EB study or prolonged monitoring outpatients with intracardiac device monitors to see if they develop a progression of their conduction disease. Now, if you see left bundle branch with the PR interval prolongation, if the QRS complex is less than 150 milliseconds, whatever the PR interval, those patients, they will not progress to complete heart block. So it is safe to discharge those patients. This algorithm, which was presented by the American College of Cardiology, was validated, and it shows good use and prediction in low-risk patient. It does really poorly in high-risk group patients. That's why some advocates for the use of post-procedure right atrial pacing, looking for a Winkie-Bach phenomenon. If the patient develop a Winkie-Bach at a lower rate of an 80 beat per minute, then possibly those patients require pacemaker. If they don't develop Winkie-Bach at a rate of 100, more than 120, then probably those patients at a lower risk of developing complete heart block in the future. An update of this guidelines is published, and this is only similar, but only it actually gives reference to the continuation of a beta blocker if the patient is taking this medication. Should not really be stopped, because stopping this medication can lead to a higher rate of complete heart block and arrhythmia post-procedure. The European guidelines has a simplistic approach, but similar way. If the patient has resistant high-grade AV block or a new onset alternating right bundle branch block, then probably this is a class 1 indication. If pre-existing right bundle branch block with new post-procedure conduction disturbance, then pacemaker is class 2A recommendations. Others are class 2A and class 2B recommendation, and also it recommends for an EP study for this patient and prolonged monitoring for the rhythm. So in conclusion, Mr. Chairman, ladies and gentlemen, post-TAVR conduction disease remain high. Many recover within 30 days. Late events remain a nuisance. Measures to identify high-risk patients are improving. Patient-specific approach is really important. Post-procedure extended monitoring is required for high-risk patients. The role of EP is a work in progress, and conduction disease post-TAVR is a challenge in low-risk and young patients. Thank you.
Thank you so much.